My talk may actually be a good introduction for the day, because although I spend a good half of my time doing research, well, I actually have three halves. One of the halves is the editing, and the third half is I run what we call the APEX, our term for EPIC at UCSF, Clinical Content Oversight Committee. And in that role, I've had the opportunity to kind of try to be right brain, left brained about the operational work that we're doing in our EMR, and trying to think about the research opportunities and implementation science behind it all. So this will frame kind of where I think all of us are going to end up being if we're working on implementation science or quality improvement going forward. I'll start off by talking about the golden age of EHR, electronic health record expansion that we're in currently. We'll talk a little bit about the impact of electronic health records on outcomes. I'll do this with a little bit of trepidation, knowing that Kaveh is in the room here and has done a lot of work in this area already. I'll talk a little bit about how problems with the EHRs, kind of known problems, kind of will inhibit quality improvement or effective programs in implementation science. I will then provide some sage comments. Some people might call them editorial comments. I'll call them sage observations. And then end with some optimistic closing remarks. I think this is a really exciting time to be doing the kind of work you're doing, and particularly in an electronic era. So just so you all know what an electronic health record is, it is more than just CPOE, computerized order entry. It includes electronic documentation. It includes automated decision support. And the decision support for the remainder of this talk, think about it in flavors. This is reminders, stops, and alerts. If you work in a VA, you know what these are like. These are also calculators, so that you get weight-based dosing, or occasionally we'll have appropriate calculation of vancomycin based on GFR, for example. And diagnostic assistance is also another advanced form of decision support. So think about, your patient appears to have a DVT, doctor, would you like to use X? It includes a patient portal so that patients can look at their own health records and do things of their own. And a data repository. This is often a vestigial organ on the EHR organism, but it's increasingly important for the kind of work you all are doing. So I don't think I'm telling you anything, but the last 3 years since the HITECH Act came out, seen explosive growth. Some work from Ashish Jha suggests that 75% of U.S. acute care hospitals who are eligible for HITECH, which is basically almost all of the hospitals that receive Medicare money, are going to are either moving to a more advanced form of an EMR or EHR, or installing one. These features of EMR, EHRs are most difficult: CPOE, automated quality measures, and patient portals. And if you're a small, rural, non-teaching hospital, it's most difficult for you to do this sort of work. What can we expect during this rapid phase of expansion? I think it's reasonable to expect, again, based on kind of early data as well as recent data, is that this EHRs with CPOE, and this is largely e-prescribing, will improve or reduce drug prescribing errors, is largely through handwriting and transcription errors. Some of these effects may be due to drug-drug interaction detection or drug allergy interaction. This will probably reduce some of these adverse events, probably reduce patient harm. But there's actually interesting data talking about how these systems also produce a lot more alerts. So you have a greater sense of near misses. So something else to think about if you're doing science in this area. For medication management, so picking the right dose of a drug, there's a potential benefit if you're using drugs that have pretty clear algorithms. So insulin is a great example. Warfarin is another great example. Heparin is another great example. But these there are only a small number of studies. And I'll stop here for a moment. And this issue of implementation science, you probably all read this regularly, has a great series of systematic reviews on EHRs and how they work and why they work or don't work. And I'd suggest you pull that if you can. I'll also mention at this point that the handout that I sent like a couple days ago is completely out of date, so I'll resend this and you can get the PDF later. Drug prescription appropriateness, so did you get the right drug to the right patient? Inconsistent improvement in kind of getting the right drug to the right patient, and is seldom improved patient outcomes. Improving clinical quality. Of 36 published studies, really moderate-sized improvement in process measures, no impact on outcomes, and then if this is largely inpatient quality of care measures. If you're an outpatient-based physician and thinking about using your EHR to screen patients who need, say, A1C or foot exams or eye exams, the data is pretty heterogeneous. Value, I think we're all increasingly focused on this. I'll spend some more time talking about costs and value later in this lecture. Clinical decision support can improve appropriateness of radiologic tests. This is where most of the literature is focused on radiology utilization. Not many of them actually focused on reducing the actual number of tests obtained, but when they did, they were moderately successful. And then effects on outcomes, cost of care, and provider satisfaction in primary care, poorly supported. Anybody who's worked in a clinic who's done an EMR or EHR installation here recently? So we just did one, so did it make your life easier? Not at all. So that's very consistent. It slows you down, particularly in clinic where turnover is much faster. Notes, orders, e-prescribing just takes longer. So it's hard. This is really the workflow in a clinic is much more impacted. So I think that's part of what we're seeing there. So what can you expect? What can we expect from all these hospitals doing EHR installations out of the box? Probably not a lot in the short term, but I always say don't feel badly. Most of QI is in the same boat. The first thing you do with a QI product is almost never going to achieve the ends you want. So important kind of realization. So I always try to think, so why is this so disappointing? You guys, everyone in this room has been thinking about implementation science or quality improvement for a long time. This is the traditional kind of translational pathway if you're thinking about moving things from like a cell or a test tube model over to improving population health. Most of the EHR data comes from 3 or 4 hospitals, and a lot of us have practiced or trained at some of them. So, there's 2 or 3 sites presented quasi-experimental data or sometimes randomized trial data from their one site in these very adapted systems. And then policy now is moving us right here. We're taking this and generalizing it widely using very different sites and using very different methods. So I think that's really an important thing. We're translating a technology which is heterogeneous to sites which have not been adapted or are not adapting to it yet. So I've made this point already. The comparability of the Indiana University or the Brighams systems, although I will say the whole partner system is now moving to Epic. So we'll see how that goes for them. But the comparability of the Brighams previous system to Epic is not clear. Brigham spent decades tuning their system to be just the way they liked it. It grew up endogenous to their culture, their beliefs, their kind of clinical priorities, the practices they had there. So it's not likely to be exactly what Epic will deliver to them from Madison. In fact, I know it isn't because I'm talking to the people there now. So a great example that I like that we've been talking about with the people at Partners is that when they built their system, they built their own database of drug allergy interactions. Epic gives you, out of the box, a set of data tables from First Data Bank that gives you the same data. It's probably good, but we don't know how comparable it is, and there's certainly questions about how frequently they're updated and how accurate they are. The next one is this thing my CMIO says, a culture eats technology for lunch every time. So if you don't have a receptive audience, certainly the Cedars-Sinai experience of their initial attempt at a EHR suggests that unless you've done a lot of work laying the groundwork with your clinical providers, you're going to have an unsuccessful or at least not as effective implementation. So I think this is partially culture, but also because human workflows, the way I used to do my job with a dictaphone and a notepad on the wards is very different than now what I do with my iPhone app and attestations in my inbox and Epic. So to get around this challenge, your day is going to change fundamentally. Most EHR vendors give you at least 3 ways, if not more than that, to achieve the same goal. We'll come back to that in a minute. Most implementation strategies argue or recommend strongly against doing stops or strong reminders in the system just to make sure people can get through their day. And even at some distance after implementation, many sites have not implemented any advanced decision support or reminders. Again, this is older data. I think we're going to get around this in a little while because a key feature of meaningful use criteria of the United States is, in fact, you've got this great machine, now you've got to use it for the intent, the way it was intended. So meaningful use means you'll turn on this advanced decision support, but certainly to this point, most places have not gone there because it interferes more with people's days. Again, I don't practice in the VA, but my friends who do, they can't get through a clinic encounter without getting 3 or 4 pop-ups of, your patient looks like they need this, or that you've got this missing, or that deficiency. So this is, the private sector vendors are much more sensitive about this than I guess the government is. Garbage in, garbage out. I think there's 2 big features of garbage in, garbage out in EHRs. One of those things I love, this sloppy and paste. So this is, we residents copy and carry their notes forward in the same exams there for 7 days. There's a great case on this WebM&M web page of a patient. Like 3 years ago, someone used the terms PE on a note. They meant physical exam, but it got moved to a problem list that the patient had a PE. So the patient not only had an inaccurate physical exam being copied, but also had a diagnosis they never had in their medical record. So kind of a classic sloppy and paste issue. Again, the other one, and I think this is also, we'll talk about maybe reinventing the note in an EMR era, is note bloat. So now you've got this computer system that automatically pulls in your labs, your vital signs, your ins and outs, the last 10 things they had for dinner, and you can blow this all into the note. So suddenly the note is 30 pages long, and the only salient bit of information for you is the assessment and plan for the day. So certainly in our EMR working group, we think about this a lot, and the cultural challenges of but I really want my vital signs in there, or I really need the labs in there is really hard to overcome. As an implementation science researcher, it becomes brutal to go through notes to look and figure out if someone's actually improved or what's been happening in day-to-day care. But from a compliance standpoint, it's also not clear whether the pre-population means you actually looked at the lab data, particularly if it's 30 pages of text. There's no way, I think, that my R1s are actually looking at the albumin assiduously every day. It's coming in their notes, but does that mean they actually acknowledge the fact the patient had a normal albumin? I don't know. Another one, and I think this is not necessarily different in the rest of our practice, but another reason why I think EHR implementation has been disappointing is that finding the best practices to translate into the EHR is challenging. In the EHR era, you'll often lean on your local leaders. Again, you've done the work to get frontline engagement from the people who are going to use the system, so you're going to go to your local champions, which is great. You get the buy-in. But often, these are people who have moderately idiosyncratic local beliefs. We have a really active pediatric diabetes group who stamped and were very upset with us because the system wouldn't do what they wanted to do. It turns out they're the only people in the country who want to do the specific kind of inpatient insulin dosing. We had to help them along to figure out how to make that happen in the system. But that meant we did have to go back to Madison and say, listen, how do we do this? We need to do some custom programming to accommodate this practice, which is probably going to come more generally to children's hospitals, but certainly we're the first in the country. That's what UCSF does. But again, this is a huge downside of being locally tailored if you're a vendor system. You can go to your vendors. Epic will give you a bunch, and I know Cerner does this and McKesson does this as well. They give you standard order sets that come from the mothership. This is great. They come they're endogenous to your software. They apparently work. They're not always representative of your local practice. So you still have to go through the vetting process to make sure the AMI order set still fits with your cardiologist's local needs or the ACC's recommendations. And sometimes they're not always right. We were going through this process about a year and a half ago looking at the order sets that came from Epic, and the renal failure admission order set had a contrast CT in it, which made little sense to us. So we pulled that and had to change that around, obviously. So about 3 years ago, I was on an IOM committee looking at trustworthy clinical guidelines. And so I put this down here just to make sure that they are cited appropriately. So some of the general criteria of these trustworthy guidelines are pretty well suited to EHRs. So presumably an EHR could help you consider important patient subgroups if you have decision support. They can give you an explanation of the logical relationships between care options and health outcomes. And because they're electronic, you don't have to pull paper order sets, restock them, worry about that file cabinet. So you can kind of the cycle length on improving or updating order sets is shorter. So it seems like a clear win-win. The problem, and this is something we didn't get to in the IOM committee, and they may be coming out with something about this soon, is taking the old technology of clinical practice guidelines and translating them into an electronic era is not a slam dunk. There's very little information out there on how to take a practice guideline and translate it into an EPIC environment or a McKesson environment or Cerner environment, because we'll talk about this in a minute, every site has constructed their order sets, their laboratories in different ways. The other reason is that complex algorithmic decision support. Think about these early warning systems or diagnostic therapeutic algorithms are often difficult to implement. Think about the things I just talked about, the sloppy and paste, other things. If the data aren't in there in a codified way, they're very difficult to implement. The other reason, I think the workflow in EHR is fundamentally different than the way most clinical practice guidelines have been constructed. So again, a big kind of distal translational break. And the other thing that no guidelines have done well yet, they always say, take patient preferences into account. Huge area of interest, obviously there's a whole institute about this now, but no one's really figured out a way to take that recommendation, either specific to clinical practice guidelines, and then take that guideline recommendation and move it to a patient portal situation. So when the patient logged into your EHR's patient portal for UAB, how do they get information out of their system to say whether or not this knee replacement is appropriate, and how does that information go back to the orthopedic surgeon or the primary care doctor to help them make that decision jointly? So it's very interesting. I mean, there's at least 5 careers of research in that particular question, but really thorny issue. And this is not only patient portals, people are getting this information off their PDAs, and there's other issues around translating these patient portals using Google Translate, and then digital patient care coaches, again, another way to move this into the electronic era. So where does the current state lead us? So you've seen one EHR, you've seen much EHR, so everyone's Epic or Cerner or McKesson installation is different. Many EHRs are a closed ecosystem, so it's very hard to add things into an Epic model. It's more like Apple if you think about the Apple. It's hard to put new apps in there. There was a nice paper in the New England Journal about this a couple months ago. I said multiple paths to a single clinical task is important for workflow, but it really makes it hard to enforce a best practice. If you've got 7 different ways to get there, you have to somehow put a roadblock or a speed bump on 7 different places, and that makes it really hard programming-wise. Garbage in, garbage out means the computers only know what we tell it. So why can't the computer do that? Because the data just isn't in there in a way the computer can search it. And there's limited evidence to implement the guidelines. So I'll transition now to my SAGE observations portion of the discussion. So the first question I have, and this is kind of a conversation inside my head, so help me here. So how will health IT solve quality? Well, I think there's a big concern in some ways that it might be old wine in new bottles. Until you solve the local culture, and create the burning platform for change around particular targets, you're not going to be able to prioritize in your EHR about the issues that need to be fixed and the design decisions to be made. So until you get the culture lined up, the prioritization set up, the commitment from the leadership, commitment from the front line, you're not going to be able to deploy your EHR fully. Again, that's probably the reason why not no one, but very few people have turned on the decision support tools in their EHRs. That is the final mile, and it's also the most challenging final mile for most clinical providers at the front line. And then I don't think we're ever going to come around the limitations, at least using the current paradigm of the guidelines, of this guideline doesn't apply to the patient in front of me. So that's never going to, EHR is not going to solve that necessarily, but it certainly is a limitation. The way I think that will help the QI can be moved forward, again, implementation science can both use this as a tool, but also study the ideas, is you have to make the interface design and decision support go together. I mentioned a minute ago about design of documentation. So does every note need to have every bit of the old SOAP note in it? It may not be the case. We're going through a project right now where our old sign-out note was basically the HMP from admission plus the to-dos for the night. And in the EMR, that's all there. You don't need it. In fact, it's on your iPad. Most of the residents are walking around with an iPhone. So all they need is just the overnight, anticipatory guidance. But peeling away the med list from the handout, they like to print out these 17 pages of paper. Peeling that 17 pages of paper out of their hands and turning it into their iPad or the iPhone's been really hard. Does the note need to recite data? So again, that's in the system already. There's also a tension in the structured notes versus unstructured notes. So many EMR vendors can allow you to do checkbox or drop-down menu-driven notes. That's great for the system because then those data go into a database. Or you can basically write it as text, which is searchable but not easily turned into zeros and ones to make your outcome variables. So natural language processing is, it's out there and people are using it now, but those are two technologies that can turn your documentation into researchable and quality improvement ready notes. And then obviously turn the decision support features on. I talked a minute ago about patients. I think the other way that EMRs will innovate, should say EHR, innovate over old models is by involving the patient more directly. And I'm really excited about this. We're doing some really neat work on patient use of iPads to educate themselves and plan for discharge, make their own appointments before they leave. This is a disruptive technology. So self-scheduling clinic appointments is a great example of what patient portals can do. So what work that we will be doing administratively that is probably useful for the patient to take on themselves. And I mentioned also the shared decision-making part, which is, again, a huge area of interest and very ripe for research. So I spent most of my flight over here yesterday trying to figure out how to fix the autocorrect on my Microsoft Word. So this is the EHR. But how can you get around this EHR, you've seen one approach? So for research purposes, it is, and I don't think anyone's solved this yet, so if you're running a research trial in an EHR system, the administrative functions for the IRB approvals and all that stuff is often not well integrated into vendor-based systems. There's enough academic medical centers now coming online with many of the vendors that this is going to be solved, but it's definitely a major issue. I'm not going to say I've got that solved. And then getting the data out, we're still working on that at UCSF, many sites. That is the biggest challenge here, and it really just means investments in the data repositories. If you want to, though, take your intervention and move it to a partner institution with the same EMR, EHR, or a related one, it's very hard to figure out how to turn that algorithm into exactly the same algorithm someplace else. It makes program evaluation very challenging as well. Clinical data repositories will solve part of this issue. There's a lot of middleware solutions out there, the cloud, whatever that is. People are using the cloud to do this stuff. I'm joking about that to a certain extent. I think people are interested in the cloud in a way to pull data out of your EMR and store it. The challenge then of getting it back in is a substantial one. But the vendors are in this space very actively. They realize this is critical to their mission for QI reasons, for health information exchange reasons, and also because so many of them are in academic medical centers right now, they can't not provide some services along this line. And then a very interesting project from the National Library of Medicine, which is just getting underway, creating a Wikipedia approach to these, describing your EHR intervention and give it kind of structure that could potentially be translatable as a project underway. And hopefully in 2 years they'll be out and you'll be able to search that. So can EHRs reduce costs? I think this is a really open question. I'll start with a little bit of discussion of cost types in healthcare. So there are variable costs. These are the costs that change as the volume increases. So you may get a slightly different price of radionuclide if you buy 70,000 gallons rather than 70. The marginal cost that if you do more knee replacements, they may be done more cheaply after a certain number. And there are fixed costs, which are basically overhead. So buildings, people, devices, equipment. The reason why this is important for EHRs is there's two reasons. One is that about 75 to 80% of the costs in healthcare are fixed costs. These are the things that are around us. They're not things we have a whole lot of control over directly as clinicians. And then we've just added this extraordinarily expensive fixed cost on an already very expensive system. These EHRs are way more expensive than the vendors are willing to tell us, I think. And they've been implemented at a time when the pressures to reduce costs are extraordinary. For academic medical centers, you add that to the setting where they probably do need a lot more customization to account for the things that we do. So transplantations, bone marrow transplants, a lot of our, just think about the things that patients are sent here from other places in the state or the region to get. So that requires vendor or local customization that is just more expensive. And you need to achieve the tripartite mission. So research and education, accommodating those requires more overhead costs. Again, sites that don't do research don't have to worry about creating a whole new research administration arm within their EHRs to manage IRB approvals and set up a separate administrative structure to approve research protocols in EHR. So this is extraordinarily costly, and again, a big deal for us at UCSF. So if you've got a shiny new EHR, you've got a few different strategies you can undertake. You can target your physician practices, you can support your existing strategies more effectively, and then you can automate. There may be others, but those are the three big buckets that I can think of. So you can choose the costly diseases. Sorry, John, there's your MI down here. And sepsis is right up there as well with you, so you're in good company. So how do you target that disease, or do you look for waste? I have this slide here just to point out there's a lot of inefficient delivered services you can go after. There's some unnecessary services. I put the arrow here in non-wasteful spending because one man's waste is another man's car payment. So think about it's all a little bit in the eye of the beholder here. So EMRs may be able to help with efficiency. They can certainly help with unnecessary services. We talked about that earlier. But if you're Willie Sutton, you're going to go after, I'm going to say Willie Loman, Willie Sutton, you're going to go after the bigger slice of the pie just to make that more efficient as well. Making the EHR is going to go after that. And that's a physician practice largely. If you're going to go after physicians, there's not a whole lot of data about how to do this. EHRs may help some of this. So the provision of cost information in primary care, this is an old study, but there's really been nothing quite much better than that in the last 15 years, 12 years. So if you give primary care doctors cost information for their commonly ordered items, the lower cost options are more often chosen, but once you take those reminders away, the practices kind of go back to baseline. And then Bob Brooke wrote this nice paper to suggest we add a checkout cart at the bottom of your orders every day, so to see how much the cost of your care would be. But most of these are educational interventions. They don't really matter whether IT or not. It doesn't really. No one's really studied whether appropriateness was improved or increased in these programs. I mentioned limited persistence of intervention effect. And then they focus really on the variable costs. This is really, again, the stuff that we do day to day as clinicians is ordering things that are largely variable costs. But no one's kind of looked at whether cutting down the number of CBCs or chest X-rays meant they could, have one fewer lab tech or one fewer X-ray tech on. And that, again, that's where the big savings in healthcare begin. A bigger challenge in EHRs, and I think this, again, I'm laying this out for you all so you can solve all these problems and figure this all out. So I think, most cost reports in the past have been pitched at the manager's level, the people who are running the division, the nursing unit. I think of my UHC reports. I never see those, but my division chief does, and our unit folks do. I think physicians are increasingly prepared to accept the idea that costs are an important issue, but whether they think their costs are important is the next kind of the final mile. So EHRs are in front of you, so figuring out a way to design that is important. And I think, you know, making the checkout cart at the bottom is only one approach. There's a lot of rich opportunity there. So you could take your EHR, again, I just talked about targeting physicians. You can help your existing programs work more efficiently. I like to think of antimicrobial stewardship as kind of a paradigm of utilization and appropriateness, kind of a classic structure in a health system. You know, in the pre-AHR data, there are some data suggest that you can reduce the costs of antibiotics directly, as well as the subsequent cost of adverse events if you've got a robust antimicrobial stewardship program. There's not a whole lot of data on whether this program is cost effective. This paper down here said that they saved 1.2 million, but it cost them about it cost them probably half that much, or slightly more than half, to run the committee that year. And the most effective programs include physician outreach and approval. So someone ordering you know, a cefepime has to call the ID fellow, and they talk about the case, and then the ID fellow either approves or does not approve the drug. So that would be the one tier. But if you didn't want to choose cefepime, just wanted to use, you know, make a less broad spectrum drug, you didn't have to call the ID fellow. So this is what I call the tiered approach. The other thing that people are doing increasingly, and again, pathways is, think about pathways as a kind of a standardization or quality improvement intervention. And I put checklists here because I think, you know, 15 years ago, we might have called checklists a pathway. Before that, they would have called it cookbook medicine. But now, they're all kind of part and parcel. Minority of the pathways and checklist literature reports costs as an outcome. They just haven't spent a lot of time thinking about it. They're thinking about the clinical outcome side, not important, but just thinking about that. The pathways and checklists indeed are difficult to build, monitor, and integrate. And they're difficult to accommodate patients who just fall off the pathway. You know, day 2, you know, someone's delirious after cabbage, they kind of fall off the cabbage critical pathway. So in this setting of physician outreach, systems focus, and pathways, how would you apply the EHRs to cost reduction? So I think the implications in the short term, in the longer term, is just using the system to provide cost and utilization data in an empiric way to the end users. Again, this might be a checkout cart, but decision support may also help this. Setting firm-ish borders and tier the options are important. This is partially decision support, but also partially, for example, we took ionized calcium off all of our order sets and saw a 50% drop in ionized calcium ordering in the hospital. It's still in the system; they can find it, but the ionized calcium is no longer easy to get to in the first step. And then reduce item level utilization through automated approvals and restrictions. Again, think about the ID fellow you have to call. That'd be one way to do it. But I think that I think the EHR industry now, and I think part of the HITECH Act is the camel's nose in the tent of thinking about automating as many parts of healthcare as we can. And I like to think about bank tellers. You know, the other example people have used is elevator operators. There are no more elevator operators. You run your own elevator. You no longer, have to go to a bank teller to do a withdrawal. So where are those jobs in healthcare, and where can they be automated? Pushing some of these to patients is important. It's not entirely the same picture as automating in healthcare, so where can that go? An example that we're exploring, and many sites are exploring, is medication reconciliation. Many sites have a standard pharmacy cross-check at some point after admission. That is probably not necessary for every patient, so how can you automate that process so that only the highest risk subset of patients need it? That is not necessarily automation, but it's certainly using the AHR in a way that deploys resources more effectively. Again, the EHR needs to be a vehicle for these disruptive technologies. can EHRs allow us to balance standardization and usability? Again, think about my friends who are in the clinic an extra hour every night doing their notes because the EHRs just crushed their productivity. So this is a graph from a Harvard Business Review paper that I like to think about. That was about productivity curves in industry. And this is from a service industry. So we're a service industry. So this is a curve derived from it's a hypothetical curve from a service industry. So having more choices is great in healthcare, but it is a huge pitfall. Physicians want to be out here. We see complexity in our patients. We want to be able to adapt to all of our patients' needs as quickly as we can. Unfortunately, the future kind of needs us down here, or maybe not there, but at this inflection point. So their kind of challenge was for healthcare and to find Model T systems. And their example was the 1908 Ford Model T was the kind of root car from which Ford made 17 or 18 different models with small modifications. More modern examples would be the Starbucks medium coffee, and if you're from the West Coast, the In-N-Out cheeseburger and fries. Like everything, all their major products come off of this central production process. So thinking about those as kind of defining your production process. So an example in ambulatory medicine will be, if you looked at your most common in clinic encounter, and it would be hypertension, pretty close to the number 1, number 2 in primary care here, I would guess. What if all you did was see patients with hypertension? What would they do to check in? How would their vital signs be measured? How would the nurse interact with them? How would the doctor interact with them? How would they close the visit out? And then, okay, so now they've got diabetes too. Then what happens? So it's modularize and add on. That's what we think about in these Model T workflows. So you can use health IT to achieve these aims. You can be a faster warehouse of these treatment algorithms. You can be a more efficient way to present all possible treatment and testing choices. These first two are not the ones I think are the right ways to go, but the guardrails around defined clinical practices. So you can reinforce a desired workflow in the EHR, but again, you still have to set the ground rules and expectations from the frontline stakeholders. Arnie Milstein, who is former chair of the president of the Pacific Business Group on Health, has recently moved to Stanford and is doing some really interesting work looking at variations in Stanford's practices around some key clinical conditions. And despite protestations from people like me to the contrary, a very small number of drugs and tests and procedures in their hospital account for 80% of the care going on there. So this is classic industrial engineering, and he's applying it to clinical practice. So the EHR can help you with this and say, listen, 20% of drugs account for 80% of the patients, or vice versa. How are we going to look at this? So you make those the defaults, again, and then set tiers of approval or decision support around the other things that are outside the kind of initial 80% bounds of practice. But I don't think the EHR can be used solely as like a more efficient all-you-can-eat salad bar. I think in many community centers that has been an approach. These are places that have a large community-based primary care referral population. They need to make sure that all the relevant stakeholders have their own order sets, their own documentation. That's been very hard for them to manage. Again, that's partially the reason why I think EMR, EHR installations have been so disappointing to date. But you can certainly get around that with more robust central decision support and central oversight, excuse me, and then be very assiduous about user-generated content. So this is not necessarily an EHR question, but the EHRs can help answer this question. It's proved to me that what this EHR is doing to me, doctor, is helping my patients. And this is really about giving me outcomes. So EMRs can collect outcomes. They can report a range of outcomes back to frontline providers in a way which was not possible in a paper era. I'm thinking about UCSF again. I would write a note, a coder would look at the note after the patient was discharged, maybe a week or two later. It would get coded. The data would go off to Chicago DUHC. Then I would get my red dot, green dot report back 3-4 months later. The EHRs allow you to cut out the middleman. So you're still limited within your site to sample size. So if you are a pediatric rheumatologist at UCSF, you may not have enough patients with Still's disease to look at your outcomes of patients with Still's disease, but you still have more data than you had in the past. If you're looking across sites, you'll still need risk adjustment. In both cases, the science, the methods for this are reasonably straightforward. There's no real, multivariable modeling is kind of settled law at this point. And again, John can talk about this more. This is really a core feature of how most national programs which have been successful at improving outcomes have moved forward. The challenges that remain, again, getting data and analyzing data. Most EHRs do not include an analytic workspace. Increasingly, they're providing you with a clinical data repository, but that does not include a workspace where you can do SAS code or R or state create a separate working environment for that. You can do SQL code there, so you have very simple crosstabs, but nothing more fancy than that. So you have to create a separate data repository, separate analytic environments, and you have to get the data into and out of the EHR, so you can pull the data out and get the appropriate modeling undone. But to actually push that data back to the same doctor for a report in their workflow is challenging. But I think this is really a critical step. So the buy-in for everything else we've talked about at this point is going to be driven off outcomes. I will be surprised if this isn't the key barrier. And again, one physician's waste is another most important therapy. So if you can go to Dr. A who's using expensive drug A and go to Dr. B who's not using that, but they have equivalent outcomes, then the discussion becomes more reasonable. And there's some really interesting informatics works from places that are much more advanced than we are at UCSF to think about integrating patient outcomes into the day-to-day. So Kaiser is doing interesting work where they're putting prognosis data for patients in their primary care clinics in front of the doctor at the time the patient sees the patient, so they give them a 2-year survival expectancy with some alerts around DNR discussions. They're not yet prompting for palliative care or symptom management, but it helps people think about, is this appropriate is this colonoscopy appropriate? Think about Louise Walter's work, or think about DNR discussions. Provision of operative risk data and preoperative evaluation, again, help the guidance of the surgeon to figure out what the expected outcome would be. And some interesting work coming out of Penn, looking at, tell me the outcomes of the last 25 patients in the hospital who had this exact same condition and what they were treated with. Or tell me my last 25 patients that had this disease. So that and is a really interesting kind of, how do you use that? What is that evidence equivalent to, and how do you use it in practice? Again, it's very important educationally, but a very important next step for most of the EHRs in the country. So some conclusions. So notwithstanding the first part of this talk, I'm extremely optimistic. I think this is an incredibly exciting time to be doing implementation of science. Health policy, meaningful use criteria are really pushing health systems to do some exciting work around electronic health records and moving it in an effective direction with all the bells and whistles that we talked about that first slide with. And then new care models demand the EHRs to do their job better. So if you're an ACO, you absolutely need integration with your primary care clinics. You absolutely need outcome data. You absolutely need cost data. So there is no more fundamental need for EHRs to adapt than this, I think. And I'll tell you, the vendors are very, very, very excited about this, and they're extremely responsive when we talk about standards or adapting Epic for our ACO needs. They are on it. Implementing the EHR is a huge system change, but once you get past this change, suddenly there's this kind of interesting cultural phenomena where the commons becomes more transparent. So people kind of understand that we're all in the same system now. There isn't like a shadow chart in the rheumatology clinic that does something fundamentally different than the shadow chart in, I'm picking a rheumatology, sorry. So I'll say neurosurgery that does something different than orthopedic surgery. So why that doesn't exist anymore. There's only one system. And you can also directly manage other key factors. Now we already talked about external forces, but again, at our hospital, just the Epic installation gave us all this sense we're all in the boat together now, and we're really one system. Our EHRs have a much shorter cycle length. We talked about that a little while ago, but I think this really is an important thing. You can identify a problem, you can tweak the system or change the orders or decision support in a way. It does require a lot of local support in terms of programming support, and the downside of our local, of the national move to do a lot of EHR installation now is that there are about, with all the systems going up right now, finding a programmer is really hard. They're all working incredibly, and they can write their own contracts almost. They're really sought after. But in a couple years, when they're all looking for jobs, you know, we'll be able to do this work more effectively. But the vendors are all, their business model is all dependent on the things that we need as researchers: share effective interventions across sites, and the ability to permit add-ons, kind of an app environment or a middleware environment. I think EHRs will slowly work my kind of learned as an intern in 1993 workflows towards what's really right for Epic in 2013. And they'll become much smarter. I think, you know, the EHR is one of the problems in the older EHR models, that they weren't particularly smart. The computing power wasn't there to kind of provide complex decision makings or diagnostic support. So I think there's going to be a nice meeting in the middle of this, as we I'll say it for myself, old dogs come to the system, and the system comes to us. I think EHRs will provide information to clinicians in a way that is much more useful than it has been in the past. And I made this point up before, but I think every stakeholder needs the data, so we're all going to be pushing the systems. And I think what's really exciting, and maybe John can touch on this, is like the generation of evidence is going to fundamentally change, particularly in those settings we're talking about. My last 25 patients, I think that is really a fundamentally different paradigm of evidence generation than waiting for the next randomized controlled trial from the TIMI group or whatever. You know, this is going to come out of your own network, your own registry, your own health system, and it's going to be very important. And it'll come from your own peers, your site, and your patients.